The goal of active surveillance is to maximize the quality of life for patients while at the same time preserving their quantity of life. So we are not putting patients at risk that this cancer is going to get worse or spread.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Akshay Sood, a James urologic oncologist who specializes in treating patients with prostate and bladder cancer. Akshay will give us an overview on prostate cancer, which is the second most common form of cancer for men behind only skin cancer. He'll fill us in on the importance of screening, all about PSA levels and what they mean, the Gleason grading system, the new trend of active surveillance, some of the recent advances in treating prostate cancer, and all about the James Multidisciplinary Prostate Cancer Clinic, a world leader in treating prostate cancer. Welcome to the podcast.
All right, thank you so much for having me here, Steve.
Now, you're pretty new here, just a little over a year. What brought you to the James?
Yeah, you're right. Just finished my first year here at James. So I think for me, coming to Columbus and to the James is kind of a combination of different things, personal and professional. My wife's family is from Michigan, and I actually did a lot of training in Detroit, Michigan before I finished my fellowship at MD Anderson in Houston. So we were looking to come back to Midwest. So that was kind of the personal side of the reasons. And then from a professional reason, I was looking to join a practice or an institute that offered me both the opportunity to provide good care for the patients, but also be part of a team that's at forefront of research. So here at James, I actually have 60% of my time is dedicated to providing clinical care to the patients, and 40% is for research. So that's what I was looking for, and I was very fortunate that the James was looking for a urologic oncologist at that time, and it kind of aligned for me. So I'm very happy to be here.
All right, well, let's dive into prostate cancer and what you do. So what is the prostate? Every man has one. So
Right.
What is it, and why does it seem to be so susceptible to getting cancer, especially as men get older?
Right. Now, those are great questions. So I think prostate, as you said, every man has it. The main function of the prostate gland itself is actually it secretes a fluid that is part of the ejaculate or the semen. And the main function of the prostate is actually during the reproductive years for a man. And the fluid that it secretes, it keeps the sperm healthy during the transportation of the sperm in the ejaculate. So it essentially helps keep the sperm safe until they reach their destination to fertilize the egg and to create a baby. So that's the function of prostate. Actually, in old age, it doesn't really serve any function as such. Now, to the second part that you asked me, why is it so susceptible to cancer? That I don't think we still know. Prostate cancer, as we know, we think of it almost as a disease of older adults. We still don't have a lot of why so many men get it and why it's so common. So there has to be some kind of evolutionary connection, but I don't think we are even close to figuring it out. Okay. But that's why I think it's a very interesting question, why it is so common. It is so common, but we still don't know what causes it really.
So if you don't know what causes it, as opposed to lung cancer where
Right.
we know smoking causes it,
right.
Does that mean that prevention is difficult?
Absolutely. So I think that is one of the reasons, and I know we will get into screening in a little bit, but there is some data to suggest that just kind of with other diseases throughout body as we get older, cardiovascular disease and other diseases, that eating healthy and maintaining a healthy lifestyle, such as exercising regularly, prevents cardiovascular diseases. Similarly, there is some evidence, very limited, that it can prevent development of prostate cancer, but we just don't know yet. The only things that we know that are associated with development of prostate cancer or putting you at risk for having prostate cancer is older age, African American ancestry, and having prostate cancer or some other genetic mutations in the family. But as you can imagine, all of those are non-modifiable factors. You cannot change any of that. So,
Do African American men get it at a higher rate? Is that
absolutely, yes.
Okay.
So there is
Even
a wealth of data that African American men get more aggressive cancers of the prostate. They get cancers at an early age. And they more commonly die of prostate cancer as well. But I just want to make sure that the last part that I said, that they die more commonly of prostate cancer, it is not due to their African American ancestry. That has been shown is mainly due to disparity in care.
Yeah.
So I think we understand this much better than we did 15, 20 years ago. And I think at the James especially, and at many other institutions, people are working to ensure that we screen patients of African American ancestry or anybody who's at higher risk differently, more closely, and then offer them treatment at the right time to at least reduce that effect on mortality.
Yes, because I believe, and you'll correct me if I'm wrong, like many other cancers, the earlier you detect and start treating prostate cancer, the better the outcome?
Absolutely. So it is a very kind of nuanced approach or a very risk-adapted approach that we take. But you're absolutely right that we want to detect cancers early on so we can either keep a close eye on the cancers. Not all cancers need treatment, but at least detecting it early, keeping an eye on it, and then treating when the time is right is the right thing to do, and that prevents death from these cancers.
Now, before we get to screening, one more question. Sure. Are there any symptoms that someone should look for and say, oh, I better go to my primary care physician and talk to him or her about this right now?
Right. No, unfortunately, again. So again, and that is, again, kind of leads into why screening is important, that almost all cancers don't, and I'm not even just talking about prostate cancer, very few cancers cause symptoms. Prostate cancer definitely does not cause symptoms. And by the time it does cause symptoms, it's often too late. Meaning that the cancer is spread usually outside the prostate. So usually the symptoms that men have, such as difficulty urinating, things like that, that usually comes from just an enlarged prostate and not necessarily from prostate cancer.
Okay, so the key takeaway is screening is vital because their symptoms are there aren't symptoms. So fill us in. When should men start getting screening, and what exactly is the screening process?
Right. So I think the first question, when men should start getting screening, if you kind of an average person with no strong family history or no other risk factors for having prostate cancer, then you should start your screening or start talking about it with your primary care at age 45. And the guidelines, most of the guidelines which we follow, such as the NCCN or the AUA guidelines, they recommend that men be screened start screening at age 45 and continue that until 75 years of age. And it's based on very, very good data. So that is a very strong recommendation from us. If you're at high risk, such as some of the things we talked about, such as African American ancestry or strong family history, not just of prostate cancer, but if you have family history of prostate cancer, breast cancer, pancreatic cancer, and some other cancers, they can actually all increase the risk for prostate cancer. So again, you should be screened early. And if you have certain genetic mutations that run in the family, that they should be screened early too. And for those men, the age is 40 years and continue up to 75.
Why does it stop at 75?
If you get detected with prostate cancer after age 75, usually it's a lower risk cancer. And second, even if we detect it, most of the time it's so slow growing that something else, what we call like a competing cause of mortality, something else is going to, something else has a much higher chance of getting you than prostate cancer.
So it wouldn't be beneficial to treat with surgery or radiation?
Correct.
Because that's not going to endanger the person's life.
Exactly. And there's no reason to find it at that time because, like you said, something else is probably going to be more important. With that, I would just like to make one caveat there that we do look at the life expectancy of men because not all of us are the same. Mm-hmm. Some 75-year-old are in really good shape. They're very healthy. So we do kind of look at various medical problems that they may have and kind of determine their life expectancy. If their life expectancy is still 15 years or more, then we do continue screening. But if on average using such as social security tables or things like that, if we feel their life expectancy is 10 to 15 years, then we have a discussion about stopping screening.
Wow, so that's an interesting sort of sub-point that if
Right.
you stay healthy, your weight and exercise and eat properly,
Yeah.
you'll live longer.
Yes.
and you actually detect that in men 70 to 75.
Absolutely.
You can sort of
Yeah.
base that. Yeah. Wow.
Right. So we have all this discussion when we see men.
Yeah.
And the other thing that you asked me is what is screening?
You mentioned PSA.
PSA,
so,
right.
Yeah.
So it's a simple test. It's a blood test. It's done with your annual physical exam. When you get other blood tests, it's just a simple check that you have to do. You don't really need any extra blood.
Right, they're doing cholesterol
Correct.
and all those other things,
Right.
and they do the PSA.
And they just add the PSA
Yeah.
on. So that's why I think, and that's why I mentioned, yes, there are some risks involved that if you get if your PSA is high, you may be subjected to a biopsy and you may need some treatment. But I think with the advances that we have in the biopsy techniques and with the treatments now we offer, it doesn't always have to be that onerous or tough for the patient because the biopsy is very well tolerated. It's a 5 to 10 minute procedure. And I always like to tell the patients it's better to know what you have and then decide what to do about it rather than try and turn a blind eye towards it. So that's why I think we have all this discussion because the PSA is such a simple test to do. And the PSA is not specific for cancer of the prostate. PSA just tells us something is wrong with the prostate gland as such. And then we can do different things, like we can do an imaging test to see if there is suspicion for cancer. And if there is, then we can talk to them about doing biopsy. So the reason I'm bringing all this up is this has changed over the last 10 to 15 years. The way we used to do screening and what came next 15 or 10 years ago is very different from what we do now.
Wait, before we get into
Sure.
that, with PSA, because I do get that every year, and there's numbers associated with
Yes.
it, and that, I don't fully understand when my primary care doctor talks about the numbers. Tell me the numbers and what they mean and what's a warning sign number.
Right. So right now, the most commonly used cutoff or the number is a PSA of 4. And if it's below 4, we consider it to be normal or
Okay.
that the risk of having cancer is low. If it's above 4, that's considered an abnormal level. And usually at that point, the primary care physicians will refer the patient to a urologist. We will repeat that PSA to make sure that it is really elevated because the PSA fluctuates quite a lot. And that's one thing I was trying to mention, that it's not specific to cancer. It's specific to the gland.
Something wrong with it.
Correct. And that could be many things. It could just be an infection. It could be just an inflammation of the prostate. It could be you did a long bike ride right before you had the PSA done. So all that could really increase your PSA.
Wait, a long bike ride before PSA could increase your number?
Absolutely, because and actually sexual activity as well, because the PSA, anything that can put pressure on your perineum can elevate your PSA. Because if you think of it, anything that can squeeze or somehow
Wow.
perturb your prostate will elevate your PSA.
All right, I'm going to ask a self-serving question here. I actually have my annual physical in like 2 weeks. How many days before should I stop riding my bike, which I do almost every day?
Usually we say 3 days.
3 days.
Yeah,
Okay,
you want to abstain from sex or any kind of heavy physical activity for 3 days before doing the PSA
Okay,
check.
all you cyclists and Pelotonia riders out there, 3 days before your PSA test, stop riding
Right.
and abstain from sex.
Yes.
Okay.
Yeah, and that just gives us a better value.
Wow, I never heard that before. That's okay.
Yeah, so we just like to double check. So anyway, if a PSA is elevated, the primary care will refer the patient to a urologist.
Yep.
And then we repeat the PSA just to be sure that it is truly elevated. And if it is above that 4 cutoff, then usually, like I said, 10 years back, or even less, 5 years back, if your PSA was above 4, the next step was to do a biopsy, which is a procedure, an invasive procedure. And it's although well tolerated, but it's not completely free of risks. But now that's not the next step anymore. If you have an elevated PSA, we almost always use an MRI of the prostate So it's a non-invasive test. It's an imaging test, much well tolerated. And based on those results of the MRI, we discuss with the patient what's the likelihood that they may have something going on in the prostate which may be cancerous, and whether they would like to do the biopsy. We also have many biomarkers, although they are not as reliable right now, so we don't commonly use those. But there are biomarkers out there. Again, they're drawn through either a simple blood test or a urine test, which can also give us kind of a probability of what's the chance of having cancer. So before we put a patient through a invasive biopsy, we do different checks to select patients who truly need that biopsy. And further, like I said, now our biopsy techniques are much better. We used to do biopsies which have almost a 1 to 2% chance of infection in the urine, a urinary tract infection, or about 0.5% chance of sepsis, meaning infection in the blood. But with our new approach, what we call transperineal prostate biopsy, where instead of putting the needle through the rectum into the prostate, and as you know, rectum is the dirty part, we put the needle through the skin underneath the scrotum. That is a clean. So with this technique, the chance of infection without using any antibiotics is only 1 in 10,000, so almost 0%.
Yeah.
And it actually also allows us to do a better sampling of the prostate, because when we go from the rectum, we kind of at the posterior part of the prostate, but when we go from the skin, we can hit the prostate at any level we want. And with MRI guidance, we can put our needle exactly where we think that suspicious spot is. So all I'm trying to say is that it's not that you have elevated PSA, the next step is biopsy. Now we have such a better kind of pathway to sort patients into different risk categories, and based on those risks, offer them the biopsy or not, or different things based on after a thorough discussion with all these tests.
So in the men that a biopsy is warranted, and then there's something there, what happens next?
Right. So I think when we do the biopsy and we do find cancer on the biopsy, that basically gives us information on what we call the Gleason grade.
I've heard of that. Okay.
Right. And then that Gleason grade is one of the most important things we look at. All the men that I see in the clinic with prostate cancer, I always talk to them that there are 3 things I look at when I make the decision about the treatment for prostate cancer. One is the PSA, second is the findings from the MRI or digital finger exam, and the third is the biopsy score. And I think the biopsy score is the most important thing, which is the Gleason score. So the Gleason score actually goes from 6 to 10. It's a little bit counterintuitive, because many patients are like, what is 1 to 5? So I always say 1 to 5 is not considered cancer, and it's not reported as such.
Okay.
So the lowest cancer, if you do have prostate cancer, the lowest cancer you can have is a Gleason 6 cancer. We are trying to change the terminology for it. We now call it grade group 1 cancer, which is the same as Gleason 6. But regardless, that Gleason 6, or it goes from Gleason 6, 7, 8, 9, 10, and that is very important to determine how aggressive we have to be with the treatment. Now, men who are diagnosed with Gleason 6, we offer them active surveillance. And I want to be clear that active surveillance is a treatment, and the goal of active surveillance is to maximize the quality of life for patients, while at the same time preserving their quantity of life. So we are not putting patients at risk that this cancer is going to get worse or spread or anything like that, because we keep a very close eye on different numbers like PSA, doing routine MRIs, and doing biopsies in a timely fashion. But because we are not offering any radical treatments such as removing the prostate or radiating the prostate, by avoiding that for some duration of time, we minimize the side effects that come with those treatments. So that Gleason grade plays a huge part in that decision making.
So at 6, you wouldn't do radiation or surgery. So at what number is it like sort of the turning point?
We have almost 2 decades of data now that active surveillance is very safe in patients with Gleason 6. So there is no reason for us to do radical treatment as long as we keep a close eye. So the turning point usually is because no cancer is going to go away on its own,
Right.
and all cancers at some point will get worse. The thing is, we don't understand or we don't have the tools yet to tell the patients which cancer is going to take 10 years to get worse or which cancer is going to take 2 years to get worse. And for those reasons, on active surveillance, what we do is we do PSA checks at a routine interval, typically between 3 to 6 months, and we repeat an MRI within 1 year of the original MRI, and also repeat a biopsy around the same time to ensure that the cancer, the grade is not getting worse or the volume of the cancer is not getting worse.
So that's the word active in active surveillance. You really are active.
Yes, exactly. And that's why I meant it is treatment, because you are undergoing different imaging and biopsies to make sure we are on the right track or we keep a close eye. We do supplement active surveillance with some of the molecular tests, which I think are really helpful. There are a couple of them out there. And what that is we actually send the biopsy sample to be tested and looked at. And these tests look at actually the genomic makeup of your cancer, and it provides an additional layer of information in addition to the microscopic examination that, even the genes that make up this cancer, they don't look to be that bad.
So you already know which genetic mutations are worse.
Correct.
And you can look for them.
Correct.
Wow.
And they can help. So that's exactly what I mean, how things have changed over the past 10 years, that we can really risk stratify patients, because based on these information, I can be very comfortable in telling the patient, look, everything point towards that your cancer is a slow-growing or indolent cancer, and we can continue to watch you safely. And at the same time, if it does get worse, which it will at some point, we can treat it. There is, again, a lot of data that if we treat it at a later point when it becomes worse, there is no we have not missed the therapeutic window in any way. So basically what you get by active surveillance is you delay the radical treatment, and the duration which we delayed, you enjoyed your life, you had perfect sexual function, urinary function, and when you needed the treatment, you got it at the right time before the cancer did anything bad to you in the sense that spreading or anything like that. And the question that you asked me about the turning point, typically we say when the cancer goes from Gleason 6 to Gleason 7, but that is also a little bit nuanced in the sense that not all Gleason 7 are the same. Gleason 7 is actually made of either 3+4 or 4+3. I won't get too technical, but typically if what we look at is the percentage of pattern 4 disease, if that percentage is getting high, then I will usually advise patients to get treatment. And again, it depends on the age of the patient, kind of the life expectancy of the patient, but typically that's when I start talking to them about radical treatments.
That was a great overview. We're going to take a quick break, and when we come back, we'll start to talk about treatment, surgery, radiation, and maybe even some new immunotherapy drugs.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Akshay, and let's start talking about treatment. And you've mentioned surgery and radiation. So talk about the advances in surgery and now actually what you do when you surgically remove a prostate.
Right. So when patients do have what we call intermediate or high-risk prostate cancer, we offer them two main treatment options. One is the surgery, or what we call robotic radical prostatectomy, and the other is radiation therapy. And in the past 10 years, I would say there has been a lot of advances in both of these techniques. When we do surgery, there are three things we're looking for. One is to make sure that we are able to remove the prostate with clean margins, meaning get all the cancer out. The prostate, I always like to explain to the patients, is like an orange.
The size of an orange?
No, the size is pretty small. I think the average size of the prostate is actually about the size of a golf ball.
Okay.
But the reason I use that orange analogy is just it helps the patients with the peel.
Peel, yeah.
So the orange, the peel are the nerves that surround the prostate. The pulp is the actual prostate. So when we do the surgery, we kind of know with all the workup that we have done, meaning the biopsy and the MRI imaging, we kind of know where the cancer is. So on the side where the cancer is, we try to stay away from the pulp, and we will take a little bit of the peel with the pulp to make sure we get all the cancer out. But on the side where there is maybe not much cancer, we can actually stay close to the pulp and leave most of the peel in the body, because that peel are the nerves that provide erection. So it's very important that we save those nerves. And I always have that discussion with the patients that what my plan is and how much of the nerves we can spare, so that they have an idea what to expect in terms of their sexual function recovery. And similarly, the prostate, the way it sits in the body, we try to, again, not to get too technical, but we try to save what we call the bladder neck and also the urethra. And I always use a diagram to show the patients what I mean. But by saving the urethra and the bladder neck, we maximize their chance of recovering their continence. And actually in the last, and we have done randomized trials, which is the highest level of evidence. And by doing these different things, we have actually shown that almost 75% of men are continent, meaning they have control of their urination within 3 months, and almost 90% within 6 months, and by 1 year, almost 98 to 99%, which is much more improved compared to 15 to 20 years ago when we used to do a lot of open surgery, when almost 20% of men will be leaking for the rest of their lives. So a great advance in surgery because of use of robotic magnification, and our tools are much finer. And same with radiation therapy. The radiation therapy now, they have so much accuracy in the way they deliver the radiation compared to the older computer methods. So now they are much more precise in limiting the radiation just to the prostate rather than affecting any of the surrounding tissues. So avoids all these side effects that we could commonly talk about.
I just want to make sure I understand when you talk about removing part of the peel and the pulp. So depending on how much of the prostate cancer is cancerous, you will remove just the cancer and the margins around it. So, and the less you remove, the lesser these side effects are going to be in terms of leakage and sexual function.
Correct. So yes, the peel is not the prostate as such. I just want to be clear. The peel is a completely separate tissue. It's the nerves
that surrounds it.
Correct. But what we know from experience is that that if you have a lot of cancer and aggressive cancer, it tends to get into these nerves microscopically. We cannot see it during surgery or on imaging, but we know it's going to be invading locally into these structures. So we, by experience, stay away from it and take a part of the peel to be safe, to have a margin, like you said. But on the side where we don't have much cancer, we can stay close.
So I know every patient is different, but can you give me a sense of, like, on average, what % of the prostate you have to remove, or do you ever have to remove all of it?
Almost always all of it. So, and that's what I meant. The peel that we are saving, we don't consider that part of the prostate. So when we remove the prostate, we are removing 100% of the prostate.
But the peel, and that's what helpfully will enable men to have better functions.
Exactly. And so that peel is not technically part of the prostate. So I think the discussion is how much of the peel we are removing versus saving.
Okay, now I got it.
Right.
Okay.
So we remove 100% of the prostate, but sometimes we kind of preserve, about, if there's really aggressive prostate cancer, say Gleason 10 prostate cancer, we probably save only about 10% of that peel. But if a patient has, say, Gleason 7 intermediate risk prostate cancer, then we save almost 80 to 90% of that peel.
And the more of the peel you remove, that could lead to
the side effects
later.
And mainly sexual function side effects, but yes.
Okay. So surgery and radiation have improved, as you explained. Immunotherapy is a big topic.
Right.
And chemotherapy as well.
Right.
So how does that fit into prostate cancer treatment?
Unfortunately, immunotherapy has not really shown good promise so far in prostate cancer, but it is a huge area of research right now. We don't really know why it doesn't work, but commonly as you said, that immunotherapy in just the past 5 to 10 years, it has completely changed how we treat a lot of cancers. But we kind of, in a more simplistic terms, we call some cancers are immunologically hot, some are immunologically cold, and all that means is some cancers respond very well to immunotherapy, such as lung cancer or bladder cancer, but some cancers don't, and prostate cancer is one of those cancers. But what researchers are trying to do is figure out why that is the case, and they're trying to not only develop immunotherapies for prostate cancer, but they're also trying to develop kind of adjunctive therapies that will turn the prostate from a cold to a hot cancer, so the body's immune system can attack it. But it's an ongoing, so right now we don't use immunotherapy in prostate cancer much. I would say pretty much none.
Let me see if I've learned anything from past doctors. So immunotherapy works as a specific genetic target, a specific protein in the the cancer cell to attack. Have you not yet found that specific target in the prostate, and that's why immunotherapy hasn't worked yet, and people are looking for that target now?
I think you're right. There's mix. So you're absolutely right that usually we do look for some mutations. But in prostate, we do know, but even then, it still doesn't work. So we do know some targets in the prostate. So the way immunotherapy works is slightly different. There is, like you said, there is a targeted therapy which goes after a specific protein, but there are immunotherapies which don't actually target as such the protein that is specific to one cancer. But what cancer is actually kind of we started by talking evolution. So cancer is actually very evolved cell in the body. It's very smart in the sense it comes up with all these defense mechanisms, so it can beat the body other cells. So what it does, it has these molecular, or it has these proteins which basically make it hide from the immune system. So what immune therapy does, it kind of reverses that, the thing that it's using to hide itself. So it exposes that, and then the body's immune system attacks and kills it. And that switch, the switch that it uses to hide itself, it's not specific to one kind of cancer. It basically is on a majority of cancers. But somehow the prostate doesn't use that switch. So that's why the immunotherapy is not very effective. But the researchers are trying to figure out how to kind of still overcome this.
So eventually the hope is they'll crack that code.
Yes, I think so, yeah.
So the James has a multidisciplinary prostate cancer clinic.
Right.
What exactly is that? And if someone comes here, and I do know that comprehensive cancer centers are where people with any type of cancer want to come. So what does your multidisciplinary prostate cancer clinic offer?
Right. So I think that, so what the multidisciplinary clinic is that it's a group of us from different specialties, such as urologic oncologists, radiation oncologists, medical oncologists, and pathologists, and also people from radiology. We all kind of have conferences, but we also see patients at the same time, meaning that a patient will be scheduled to meet all three of us, meaning the urologic oncologist, who's typically the surgeon, radiation oncologist, who offers radiation therapy, and medical oncologist, who offers systemic treatments such as hormone therapy or chemotherapy and things like that. So they will have a consultation with all of us on the same day, and we all provide our perspective, and we kind of go over the details of what each treatment has to offer, what are the side effects of those treatments, how effective are these treatments in controlling the cancer. And I think as a group we come together to tell the patient or discuss with the patient why we think one path versus the other is more beneficial to that particular patient. So I think it serves as one consolidative appointment for the patient where they can get a lot of information on the same day. And I think getting information from all different experts in their own respective fields helps the patient see why one may be better than the other. So I think that's the kind of power of this kind of consultation.
Yeah, the power of 5 or 6 or 7 smart people instead of one.
Yeah, yeah, absolutely. And I think it's also, to be honest with you, I think, it provides the patient a more balanced counseling in the sense that sometimes patients may just see one physician and they may just offer what they do rather than telling them about all the different options. But when you are meeting with all different doctors, they can provide perspective on all different treatments. And not, all of us have experience in our own fields. So I think it's good for the patient to hear all sides and then make their decision. Because I always like to tell patients numbers and give them what they should expect. Meaning, again, whenever I talk to them about treatment, I tell them that they need to think of the treatment in terms of 3 things. How effective is that treatment in controlling the cancer? And what are the 2 main side effects and what can they expect? Meaning, how will their sexual function be after the treatment, and how will their urinary function be? And I think by giving them those numbers, like what other patients have gone through, I think it helps them come to a decision, because ultimately it's their decision and they have to live with it. So I think it's better if they understand what they're undergoing and then choose.
Well, thanks for that great overview, and it's evident that you really care about your patients and research that'll help them even more. So what motivates you to do what you do?
I think maybe 2 things, if I was to break it down. One, obviously trying to do the best for the patients that I see, because a lot of patients come, and not that I expect them to know anything about this disease. They didn't go to the med school. But I think what motivates me is trying to explain to them and reassure them that fortunately, I know nobody wants to hear the word cancer, but I think fortunately prostate cancer is one of very treatable diseases. So many men who have it may not even need aggressive or radical treatment, and we can just do active surveillance or watch them and keep them safe. But even when we do treatments, I think treatments are very effective in, I don't like to use the word cure, but it is very effective. Like I said, almost more than 95% of men will not die of their disease when we treat them. So it's very, very effective treatments. But at the same time, trying to minimize their side effects and provide them with a good quality of life. So that really motivates me to provide the care. And I think we have already had advances, and that has been part of my research that I've done, improving surgical care and providing more targeted and more precise treatments for the patients to give them the best cancer-free life, but at the same time preserving their functional quality of life. Other thing that I think motivates me to do what I do is to understand, like we started the talk by you asking me why so many men have this cancer and we still don't know. And that is the other part that I focus on. Is actually a lot of my research is focused on understanding how cancer develops as men get older and why some cancers spread while others don't. So that's, I think, a big part of my motivation is to work with the patients. And I have to say the patients are very generous. When we talk to them, they are more than happy to provide some of the tissue that we obtain during either biopsy or surgery, and we use it anonymously for research. And I have never encountered a patient who have said no. So they are very generous, very willing to help other patients who they don't know by providing these tissue samples, which are critical to study and essentially help us learn what is the difference, how has this disease developed, and how this disease spreads. So we are doing a lot of translational research in this field at the James to try and understand. And hopefully, I kind of joke, but that our goal as a group of physicians will be hopefully in that next 25 years nobody has to undergo surgery or radiation, and we can either detect the patients and treat them completely non-invasively, or basically watch them. So that will be the ideal, because I think that will provide them with both the greatest quality of life as well as have a cancer-free life.
Wow, that's a great goal. Well, thank you for filling us in, and this is an important podcast and something every man should know.
Thank you.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.